Thanks, Andy. That's a tall order. Last time I stood between you and coffee break, and now between you and lunch. And so I don't know who came up with this schedule. So I could give a brief review of MS for those of you who are less familiar with it, and then tell you some new things that are happening in the field. One of them is really how we diagnose it using MRI and these new McDonald diagnostic criteria, and then tell you a little bit about some of the therapies that have been proven definitively to work for MS, including the latest one. So as I just told you about an hour ago, MS and all these autoimmune diseases involve a genetic component, an environmental trigger, which play into how your immune system responds abnormally. In MS, there's a lot of inflammation. There's then damage to the myelin coating around the nerves, and we presume that there's secondary damage to the axons or the nerve wires themselves. We can see under a microscope that the nerves are definitely damaged. I told you about pathogenesis, and so we'll skip this. The evidence that MS is an autoimmune disease partly comes from the fact that immune modulating therapies are the most successful therapeutic approach right now, and they decrease the number of attacks patients have. They dramatically decrease the number of spots that we see on the MRI. And so we think that this makes a lot of sense to try to modulate the immune system. Where do you see MS? It's an interesting disease because it has this geographic prevalence in the further away from the equator you are, the more MS there is, at least in populated areas. And so that the red here is sort of a high prevalence area in northern U.S. and Canada, Scandinavian countries, northern Europe, and the United Kingdom also have a lot of MS. And then down in New Zealand and southern parts of Australia, you see a lot of MS. And then it's somewhat lower in southern U.S. and down in southern Italy. There's a gradient north to south latitude as well, and then lower prevalence in these areas. It's not that it doesn't occur, but it's just half or a quarter as common. This information has been interpreted two ways. One, it could be environmental. That would be sort of the obvious thing, and there's a lot of interest in what's different about the environment. I told you a lot about viruses in the previous talk, and of course in northern damp latitudes where there's a lot of moisture in the air, not a lot of sunlight, we're more exposed to viruses, and they're more parasitic type infections here, which may be activating that Th2 arm of the immune system. So the environment may be a trigger because of just repeated exposure to common viruses. Another interesting feature that's come out recently is a story about vitamin D, and many of you may know that vitamin D is important for healthy bones. Women are supposed to take vitamin D and calcium. We recommend that, actually, and we have been for a while to prevent thinning of the bones. But it also turns out that vitamin D is important for a healthy immune system, and you need sunlight, actually, to make active vitamin D. And so there's a theory that maybe in these northern damp latitudes where we have more rainy days than sunny days that we might not have enough vitamin D, and indeed there is evidence that this is a predisposing or risk factor for MS. And so again, the story is evolving, but we've found recently that vitamin D can be very important for, if you don't have enough of it, you get more of those Th1 viral activating cells, and the more vitamin D you add, you get more of a Th2 response. And it's so, in a clever way, it may be Mother Nature's way of, if you get a lot of sunlight, you prime your immune system to responding to parasites which are prevalent in that area. And in northern damp latitudes, without sunlight, your immune system gets shifted towards an antiviral response. And so it may be sort of a built-in way of regulating your immune system depending on the weather as to what it's likely to encounter. But of course, too much of one thing is a bad thing. The other interpretation of this is the genetic one, so that, as I told you, the geneticist would point out, well, who lived here and migrated over there? Well, of course, a lot of Northern Europeans, Scandinavians have migrated to northern parts of this country, and there were folks from the UK who were moved down into this area. And so some of it could be just migration patterns and gene pools moving from high-risk area to another high-risk area. MS is one of the most common causes of disability in young adults. In fact, it's thought to be the second most common after trauma. The absolute numbers that we know are that there are 250,000 to 350,000 affected in the U.S., but some studies have suggested that there may be a lot more MS and that we're not recognizing all of it. This is, as with many autoimmune diseases, more common in women than in men. In this case, 2 to 3 to 1. As I just showed you, it's more common in certain areas like Northern European descent, and we know that there are people who have certain genes that they inherit, such as what's called the HLA-DR2 locus that's very common in that gene pool. The age of onset is typically sort of after puberty up to about 50 years, but we recognize, and there are lots of reports in the literature of pediatric cases of MS, as well as personally diagnosed many people in 60s and even heard of cases in the 70s or 80s. However, many times if you talk to people, there are things in the history that suggest that it had started earlier. This disease is a huge cost to society. It takes young people out of the workforce or out of the ability to care for their families, and so it's a huge medical problem that deserves attention. You probably know that there are different types of MS. The most common is this relapsing remitting form. Many times people will recover fully from the first attack, but not always. And so I have people who, their first attack, they may only recover 80% or 50%, and they ask me, am I progressive because I'm not recovering? And the answer is no, that unfortunately some people have damage to their nerve fibers right at the time of the first attack that doesn't always fully recover. And I showed you how depending on maybe on how many T cells come in and how many axons or wires they cut, that may determine how much you recover. And then as time goes on, disability will accumulate if the patient's disease is not controlled. And in some types of relapsing remitting MS, if you follow it for 10, 20, 30, 40 years, they will evolve into a progressive stage. The progressive stage is not as well understood. Initially, we thought that it's just harder to notice an attack if you already have, for example, a paralyzed leg. If you have another attack in that leg, how much more can you get worse? And so maybe just people aren't noticing their relapses. But increasingly, we're understanding that there may be a second process that happens in nerves that have been stripped of their myelin, that nerves actually start to die back and progressively get worse through a degenerative kind of mechanism. And so I sometimes make the analogy of a tree with a bark around it, and the immune cells or the weather are attacking that bark and destroy it, and that's sort of the first round of attack. And then the tree that doesn't have its bark is exposed to the elements, and the trunk eventually sort of will degenerate. And that's what happens to each of those little nerve wires that have lost their myelin. They become unhappy. And so increasingly we recognize that our task is harder than we initially thought. That not only do we have to stop the immune system, but that we have to somehow remyelinate or repair or supply growth factors to the nerves to prevent them from undergoing this degenerative process. There's rarer subtypes. About 10% of people will progress from the onset without attacks. This typically happens a little bit more commonly in men and people in their 40s and 50s, so a little bit of a later onset. Some of these people pathologically look identical to the relapsing remitting, but it may be that this is just a slightly different trigger or a response to the injury that causes that. We still don't totally understand why people follow this course. And then there's an even rarer course where people may have a different pattern. So at any given time, the majority of people will have relapsing remitting. As I told you, some of these will convert to secondary progressive, and then you see these other two types. Just to review, MS can cause a lot of things. So unfortunately, when you have a disease that attacks the brain and spinal cord, it can cause trouble with vision. Folks can present with loss of vision in one eye, blurred vision, pain behind the eye. That's an optic neuritis. Or there can be double vision or blurred vision on the basis of tracking problems. So you have nerves that keep your eyes tracking together like windshield wipers. And if one of those windshield wipers isn't working, the other one continues to look left and right, and then you will see double because two images are coming into your brain that are not lined up. And so you can have different kinds of vision problems in MS. Sensation, it can be loss of sensation, it can be short-circuited sensation, so that people complain of burning pains, tingling, all sorts of different kinds of sensory problems can happen. It can be in one side of the body, it could be one arm, could be could present like a carpal tunnel initially and then move up the arm, or it could just be the bottom of the feet and move up towards the waist. A lot of people have sensations of bands around their limbs or around their trunk, and that's very characteristic of spinal cord demyelination. Fatigue is a big part of MS. There's often this overwhelming sense of fatigue that's not just being sleepy tired, but a lot of my patients describe it as if someone pulled the plug on you at 2 p.m, that you just kind of wiped out and you had no juice. Fortunately for some folks, 30 minutes or 60 minutes of just resting can recharge them enough to get through the day, but other people really have to significantly modify their schedule and conserve energy. The motor dysfunction is obviously one of the more disabling aspects of MS. Fortunately, not everyone gets that. We see some people who are mostly sensory and visual without that, but some people will start having a foot drop, and then a whole leg will not work, or it could be a transverse myelitis kind of presentation that evolves into MS with more diffuse motor damage. Bowel and bladder, also all those nerves, as Carlos Pardo told you, they go to the bowel and bladder and involve sexual function, travel through the spinal cord, and those get affected. And I found that many times patients are a little bit hesitant to talk about that necessarily, and so it's important from a care provider side to address these issues and point out that they could be related to MS. I think a lot of people sort of pass it off as, well, I've had a lot of babies or something, and that certainly can cause bladder problems, but MS does cause both overactive bladder, having to rush to go and not being able to control it, and the opposite problem, not being able to initiate the stream or get things going. And there are medications that can help with that. And the same with the bowels. There can be problems with urgency and the bowel contracting or just not contracting enough, and constipation. This is a disease of the brain, so it stands to reason that people will have trouble sometimes with thinking and their emotions, and there somehow is a stigma about that, as if that's something different, there's something wrong about being depressed, but there's not at all. So Dr. Kaplan will talk about this more, but this needs to be addressed and fleshed out, and that sometimes this inflammation and demyelination can cause short-circuiting of some parts of the brain, and the more you understand that and identify it, you can compensate. So the wonderful thing about the brain is that you can use other parts of your brain to compensate, and that most of us probably don't use all of our brain, so that increasingly we're trying to sort out, is it a problem with verbal memory, visual memory, spatial memory, and if so, then if you know about that, you can make a list, or you can compensate in some other way. And the emotional part is huge, because depression then just takes the wind out of you. If you don't have the will to fight it, then you don't want to go on therapy, you don't want to do your physical therapy. And so being able to understand that this is not just because you don't care, you're apathetic, it's a chemically mediated depression, that we know that these immune cells in the brain cause changes that make you feel down. It's not your fault, but it's a treatable aspect of the disease. Neurologists and the nurse practitioners and physician assistants have techniques to try to identify and quantify the degree of loss. So we have all these tools that we use. Dr. Pardo mentioned about the pinprick, and we have the ability to perceive a tuning fork and vibration, and we're trying to sort out which pathways are involved so we can understand how the MS is affecting people. When muscles are weak, they sometimes go into a spasm, and so you hear about spasticity. The reflexes when you tap on the knees can be exaggerated and kick out. The toe response when you scratch the bottom of the foot will go up. We call it a Babinski response. There can be trouble with coordination and tremor as you reach out for an object. The eyes don't track right, so not only do they get off kilter, but sometimes they jump or have what's called nystagmus. And then there's loss of control of bowel and bladder in some situations, and these are things that can be recognized by the physician and then discussed. This issue of fluctuation with temperature is actually a big one. So many of you probably know that after demyelination, some people in particular are very sensitive to elevations of temperature. And so I always tell one story of a patient of mine who was out sitting by his pool and fell asleep in the sun and woke up and was so weak that he couldn't get out of his chaise lounge chair, but knew that if he could roll himself into the pool that he would then recover his function, because it can happen that quickly. But this, it sounds like a very dangerous thing. You're paralyzed here. You can't stand up, but you're going to roll into a pool. And the guy actually told me that he was so confident because it had happened before that he rolled himself into the pool and within 5 seconds swam out and was able to push himself up. And so don't recommend that. Don't try it at home. But it's a dramatic example of how temperature fluctuations can affect MS. So we actually recommend cool packs. They make these rings you can wear around your neck. They're cooling vests, and for some people it can make a dramatic difference, especially on these hot summer days. So what's happening under the microscope? Well, there's a reason why we're all focused on these immune cells, because here's a blood vessel, and you can see all these immune cells, T cells, and some bigger cells, probably macrophages, that are coming out of the bloodstream. They're following the scent that the chemokines have laid and said something's going on in the brain or spinal cord, and so that's why we target those. And then we see these bigger, fatter cells, the antigen-presenting cells, or the macrophages, are also going around doing something. Increasingly, we're trying to image the nerve. So this is an electron microscopic picture of nerve fibers cut. So it's as if you had a cable, and now I'm going to cut it up like a pepperoni slice. And we can see some of these nerve wires are fully myelinated. There's a thick black band around them. Some of them have thin bands. Their myelin has been damaged and then partially recovered. And then some of them are completely damaged and collapsed. And so there can be degenerating fibers in there that unfortunately haven't recovered. Dr. Bruce Trapp in Cleveland nicely demonstrated this, although it was described by Charcot 100 years prior. We have pretty pictures that can quantify the number of these nerves that are cut and then ball up, if you will. We call them a spheroid. And we can see now under our microscopes areas where this red myelin is stripped off, and you're left with sometimes intact green fibers, but sometimes they ball up into these. And so trying to rescue the process before the nerve wire is cut, in my opinion, is going to be critical, because once it's cut, then you're talking about like a spinal cord injury where you have to basically grow new nerves, and that technology is further off than rescuing nerves that are partly damaged. I'll point out the good news is that some of these nerves don't conduct impulses very well, but they're rescuable, so that you hear these scenarios, Kara and other people who are paralyzed and then come back, and presumably they've remyelinated and nerves were not cut, they just weren't conducting the impulse. And so more and more, if we can find how to get those nerves to conduct the impulse from A to B, brain to spinal cord, then maybe we can get people functioning better. And a lot of my patients tell me they have good and bad days, and sometimes on their good days they can get up. So they say if someone is mostly in a wheelchair, sometimes they can get up and actually take steps for 20 feet. I love hearing that, because that tells me, okay, the wiring is intact enough that if I can just get in there and remyelinate or juice it up a little bit, that maybe we can get that person functioning better. Now, maybe they're not going to run a marathon, but it can sometimes just a little bit of a difference can have huge functional effects and quality of life. And so we think that probably in everyone that there's some intact wiring left, and if we can just enhance it, that will help things. So this is the cartoon of the process, the immune cells, T cells crossing the blood-brain barrier, going in and causing that attack. And normally the myelin sausage coating around the nerve wire allows the signal to jump down from the nerve. And in the case where the myelin has been disrupted, the signal dissipates. So only 20% of it gets through. And so I was just talking to someone at the break about fatigue and why is it harder to function. Well, your nervous system is working overtime to get the signal from here down to the other end. And if half the current gets dissipated every time you try to send a signal down, it keeps firing and says, okay, I really want to lift my leg and do this. And so it's hard work. And so someone who has damage to the nerves or the myelin, they're having to work harder, and stands to reason that they're going to get fatigued sooner. So we recognize that there's inflammation and some mild nerve damage in the beginning. Sometimes this accumulates with relapses. We can measure this on MRI, especially with these gadolinium-enhancing lesions. But later on, that nerve damage accumulates, and people are less able to compensate, because instead of being 20% damaged, there may be 30 or 40% of the nerves are damaged, and it becomes harder and harder to compensate. And we see other things happening on the brain MRI where there are more punched out lesions, and sometimes as those more nerves are damaged, the brain just collapses a little bit, and that's what we want to avoid. We want to prevent this stage or reverse it. And so we try to determine where people are in their stage of their disease, how many relapses, how much tissue volume is affected, and so we're using MRI as sort of a window into the disease. But before I talk about that, I'm going to just talk about a little bit about the diagnosis. It remains a clinical diagnosis. There's no single test that we can do to say absolutely definitively you have MS or you don't. We're working on that, but right now we define it as two neurological events that have to be ones that we typically associate with it being in the brain or spinal cord, and they have to be in different parts of the nervous system at different points in time. So ATEM by definition is this sort of one-time fulminant attack. You heard occasionally it can recur, but for the most part, that would be a one-time like transverse myelitis. In MS, it then comes back again and then again and again, and in different parts of the nervous system. So MRI might be very useful in detecting that because unfortunately our ability, even when we do all the testing at the bedside to find spots deep in parts of the brain, is somewhat limited. And so we're now starting to use MRI to help make this diagnosis. The final caveat here is that you have to consider all the other things that can cause this: strokes, other mimicking diseases, B12 deficiency. So we go through a whole panel of tests to rule out other things. So how do we use MRI? We use it to diagnose. There's data to suggest that the number of lesions and the volume of lesions in the time of an acute attack may predict the future course of MS. We use it a lot in our clinical trials because it's a nice way of objectively quantifying outcomes where there's no bias. And we're increasingly using it to try to understand the pathology of the disease. And so in the situations where we do get tissue, we look back at the MRI and say, okay, what was the MRI really telling us? And you saw in the ATEM talk that sometimes all those big white spots can go away. And so much of what we image on the MRI right now is water or inflammation, and that's not the whole story. So you can see these lesions that look scary, but actually can be reversible. And I'm going to tell you that what we really want to now do is image nerves in addition to imaging just the water or the inflammation. Here's an example of how we might use MRI in the diagnosis. A patient, say, presents with an optic neuritis, but you get a brain MRI and see some white spots there. We know that their risk for developing MS is higher, but they don't have MS yet because they haven't had a second clinical event. If you get an MRI and follow-up and then see a new enhancing lesion here, in this case you see two enhancing lesions, and on this sequence you see the development of two new T2 plaques, that person now can be diagnosed with MS as long as you've ruled out other causes of these white spots. And so rather than waiting for one of these spots to hit the spinal cord or the brainstem or something that is at a bad location that will cause bad symptoms, we feel more comfortable about just diagnosing MS based on the MRI showing us that there are new plaques forming. And I think that's important. Here are some of the data showing you how the lesion load at onset predicts who's going to turn into MS and how disabled they are. And we have this disability rating score so that if you have a lot of lesions in the beginning, it's more likely, it's a 90% chance that after 5 years you'll have what's called clinically definite MS or second attack, and that 52% of people will have a disability score greater than 3, as compared to if you have an optic neuritis and you have a normal brain MRI 5 years later, only 6% of people will have developed definite MS in this particular study, and 0% of them were badly disabled or had any kind of disability. And so it is helpful, I think, in a lot of situations. What are the different sequences that we have now? Well, you've seen these T2-weighted sequences, we call them FLAIR and T2, where you see the white spots often around the ventricles. When one gives gadolinium, the contrast agent, into the blood vessels, if it leaks out of the blood vessels into the brain, we infer from that the blood-brain barrier is permeable, and we know from experience that there are inflammatory cells getting across that blood-brain barrier. So each of these ones that's lighting up with the contrast has active inflammation in it, and we're much more aggressive about treating that. If we don't see active inflammation, it's less likely that steroids or Cytoxan or even the MS drugs are going to be effective. I'll point out that some of this is sampling error, so some of these will only enhance for weeks at a time, and if you have a brain MRI once a year, you may miss the time of inflammation, and so the disease kind of activates and then quiets down. increasingly we're trying to understand what these so-called black holes are telling us. We think that this may give us some information about the underlying integrity of the nerves themselves, but it turns out it's not a great way of looking at them. And you heard from Anita that we're developing new methods, something called diffusion tensor imaging, that actually may help us look at the tissue and the nerve fibers themselves better. Imaging the spinal cord is obviously important. This looks like it could be TM. It's actually an MS patient with a TM-like lesion in their spinal cord, but this is obviously a bad location where we want to avoid the inflammation. I think we have to be careful so that now that we're incorporating MRI into the diagnosis, you have to think about the mimics, and so that your healthcare professionals go through there in their mind and say, okay, well, what's this person out camping? Could they have had Lyme disease, or do they have joint pain and rash, and is it lupus? Are there is a history of infection such as an HTLV, or do they have lung involvement as in sarcoidosis? And so you have to kind of put the picture together and think about what else can cause these spots. And so it's very important not to totally rely on the MRI. It has to be part of the clinical picture. So what are we using to treat MS? There are now 6 FDA-approved drugs. So when I started in this field, there were none. And so it's been an exciting 15 years for me just to see the advent of the interferon beta drugs, of which we now have 3 flavors, Avonex, Betaseron, and Rebif. Glutamer acetate, also known as Copaxone, came out. It's been shown to be effective. Mitoxantrone is a chemotherapy, also known as Novantrone. This is approved for worsening types of MS, and we know that these chemo drugs, by knocking out all the bad cells, have an effect, but they have more side effects as well, and they can be dangerous. And natalizumab is the newest kid on the block. This is Tysabri. It's given once a month, and I'll talk more about that because it's the latest, and there's some controversy about when and how to use that. So this summarizes the efficacy of the first, the interferons and the Copaxone drugs, and you can see that there's been a lot of talk about which one's better, but for the most part, they all reduce activity on average by about 1/3 if you look at relapses, more so if you're looking at the MRI because the MRI is more sensitive. And the response is different. So it's not that everyone has a 1/3 response across the board, but I've seen some people have one patient who went on Betaseron in 1988 as part of the initial clinical trial, was having a lot of attacks, a lot of MRI lesions that we would have predicted he would do poorly, has never had another attack again. So for all practical purposes, he's in long-term remission, albeit he's having to do the injections. And then there are other people who go on these medications and had 2 attacks the year before and have 2 or even 3 the year after, and it's as if they don't work. And so not every drug is right for everyone, and we're trying to figure out how to predict that, but it's a little bit like headaches. One person takes a Tylenol and takes care of it, and another person tries 10 drugs and enters a migraine trial because they're still having headaches. And so Dr. Howard Weiner, who's speaking tomorrow, has written a nice book you may have read called Curing MS, and I think that's what we're doing. I think that we're slowly helping some people a lot, some people moderately, and then we have work to be done for other people. So this drug showed a lot of promise. It's a monoclonal antibody that targets, there's a picture of an antibody, and you can now make these antibodies that target specific proteins or receptors on the surface of cells. In this case, it was targeting one of the adhesion molecules or sticky receptors that allow the T cells and B cells and monocytes to stick to the blood vessel walls and get into the brain. So normally you have an immune cell. It expresses this receptor, it sticks to the blood vessel wall, and then allows it to slow down enough and to migrate into the brain or spinal cord and do its thing. In this case, you come in with the drug or the antibody that blocks that interaction, and so it specifically prevents the cell that has that sticky receptor on it from going where it needs to go. And we know from experience that a lot of the cells that get into MS brain and spinal cord express that receptor, so we thought it would be a good thing to target. And in fact, it was. It turns out that in 2 large clinical trials, folks who got the drug had many fewer relapses as compared to people who were on the placebo. And there was a 68% reduction. So that's as compared to about the 1/3 reduction on the other drugs. And And there was so much excitement when that happened that the FDA actually fast-track approved the drug based on 1 year of data, although this held up for 2 years. And they said, you got to continue the trial, and everyone has to finish 2 years. We're going to start the approval process early. And so it got on the market based on some of these data. The risk of relapse over time was reduced, and the number of active enhancing lesions was reduced by 92%. This is a phenomenal figure. So you're almost shutting down the disease. The people who had breakthrough, there was a subset of people who developed antibodies that neutralized the effect of the drug, but people who didn't pretty much had almost 100% reduction in inflammatory activity on the medication. The infusions, for the most part, were safe and well tolerated. Common adverse events associated with the drug were headache, fatigue, and arthralgia, but these were often not much more significant than what the people taking placebo were. So when you do a trial, you actually ask people, anything that's happening to them. We all get headaches and occasional symptoms, but the differences between the drug and the placebo were not very large. And most of the patients that we had at our center on this medication said that they loved it. They couldn't even tell if they were on it or not. The proportion of patients with serious adverse events was similar, so there was nothing that really stood out in the 1,200 patients who were exposed to the medication as a large group. The incidence of minor infections or serious infections was 1.3% on placebo, 2.1% on the active natalizumab or Tysabri drug. Again, you can see how small these differences might be interpreted as just noise, or there could be something serious hidden here. And so we looked at bladder infections, 15% on placebo, 18% on natalizumab. These are not dramatically different numbers. And the initial data was that there were no what we call opportunistic infections or rare things that you wouldn't expect. There was no increased risk of getting cancer while on this drug. 1 or 2% of people had allergic reactions, and it's important to know that because probably wouldn't expose those people to the drug. The major side effect of the drug that then pulled it off the market was what I told you in the earlier talk, is that very rarely patients get a viral infection from a virus called the JC virus that causes a disease that we call PML, or progressive multifocal leukoencephalopathy. And PML is something that has been most commonly been seen in HIV AIDS, where the immune system is deficient. And it's a virus that many of us are probably exposed to in children, like chickenpox or Epstein-Barr virus. About 80% of us will test positive by antibodies for the JC virus. And it lives dormant, and as long as your immune system is pretty functional, it just can't reactivate or cause much damage. But if your immune system is not working because you've got AIDS, you can get this PML disease. And in the case of being on this medication, the immune system is only not working in the brain because the drug is preventing the immune cells from going there. And so, as I said before, the virus gets smart, figures out, I'm going to go to the brain and start replicating because you can't find me in there. And why that only happened in 2 out of 1,200 patients remains unclear. They were both on Avonex interferon also, and so some people have said, well, it was the combination was too strong. Unfortunately, we saw a third case in a trial of Crohn's disease, but that patient was also on other immunosuppressive drugs, steroids, and other things for their Crohn's disease. And so there's hope that maybe if we use Tysabri by itself, we won't see this again. But we really don't know, and there is real concern that because of the way the drug works and because it's so potent, that people could be at risk for getting this infection. And we saw 2 cases in 2 years. How many will you see if 10,000 people or 20,000 people were given this for 5 years? And so that's the real concern. The FDA has said drug can come back on the market, but it's going to be very tightly regulated. There'll be a registry where patients' information will be recorded. The patients and the healthcare providers will be educated about the signs of this infection and the symptoms. Unfortunately, the infection can look a lot like MS, and so because it causes damage to the myelin-producing cells in the brain. So it's a tricky situation in that we have a drug that's more effective than anything we've had previously, but it comes with a dangerous side effect in a disease that doesn't typically have any life-threatening effects. And so that's where we are. We anticipate it'll be available in about a month again. So final point here is that I told you that we're better at targeting the immune system. We have drugs that do this, and some people they're effective. We need to pay more attention to what the mechanisms are that cause damage to the nerve, so that we're getting better. Now we're using DTI to image nerves. We're imaging nerves in the back of the eye with a new piece of machine called OCT. And we're trying to develop neuroprotective drugs. And Dr. Keswani and some of the other people, I think, will talk about this later in the symposium. But this is a whole different aspect of the disease that we haven't targeted, but trying to protect nerves that have lost their myelin from undergoing further damage, and understanding the pathways is an area of huge interest that could lead to stopping progressive disease. And the same kinds of things could even actually help repair, because if we understood how nerves degenerate, we may then be able to provide the signals to make them function better. So the future is better understanding of the disease through understanding the genetic aspect of it, what the different proteins are that are being changed, and imaging. I think we're already seeing more specific immune therapies. On Saturday, I'll tell you about the future ones, the ones that are being tested that look promising, like rituximab, and neuroprotective approaches, and finally restorative approaches are happening in the laboratory. Dr. Kerr and other people are working on the stem cells, and I think that we're going to see this kind of thing translated in the next 5 to 10 years. Thank you for your attention.